and begin our evening program. And it should be very interesting. We're going to have 6 different presenters talk about best practices for managing genetic aortic disease in the COVID era, care, research, and education. And the principle here really is, in COVID, we want to pivot from victim to victor. And we're going to hear each from Len Girardi, Joe Caselli, Mark Lindsay, Shreen Shalab, Maral Ozonian, I'm sorry, I'm bad with names, and lastly, Teru Suzuki. So we're going to start tonight with Len Girardi from Weill Cornell Medicine. Len, welcome to the GenTAC Summit.
Kim, Len is not, has not joined yet, so I'm going to add the rest of our speakers from this section.
So let's.
Now, Len Girardi is there. Len Girardi is on.
Maybe Len's on mute.
I got it. Hold on. I just need to promote him to panelist. And he'll be here in just a moment.
How about now?
There you go.
We hear you.
Great. Thank you all. Who's going to control the slides? Bruno?
Yep.
Thank you. Thank you, Kim, for the introduction, and thank you for the invitation. I'm just going to briefly discuss our experience here in New York at Weill Cornell during the pandemic that occurred starting in March, and we're still sort of working through that these days. Next slide. So on March 7th in 2020, the state of emergency was declared in New York State. And we began to see, as you can see from the bar graph on the lower right, we began to see a rapid and massive influx in the number of cases into the emergency rooms throughout all the hospitals in New York City, throughout New York State. And 4 days after the state of emergency was declared, the World Health Organization declared COVID-19 a worldwide pandemic. To date, New York State has accounted for close to 500,000 total cases, a majority centered in the 5 boroughs of New York City, and New York Presbyterian Hospital, the University Hospital for Columbia and Cornell. We took on nearly 3,000 of these patients over a very short period of time. Next slide. In response to the pandemic, there was a need to rapidly restructure critical care infrastructure to account for this, massive influx of patients. On a day-to-day basis, we run about 114 critical care beds throughout the Weill Cornell campus. We rapidly exceeded that number and had to come up with ways to care for these patients in a reasonable critical care environment, and making beds and resources where we really didn't have them. Within a short period of time, Governor Cuomo also eliminated our ability to do elective surgery. And so we had to come up with a way to still perform emergency surgery and urgent surgery for abdominal emergencies, cardiovascular emergencies, et cetera. But it wasn't just to take your word for it. So we had to have an executive committee that was constructed at the hospital level, composed of 3 surgical chairs, high-level administrators, and ethicists, who each case by case had to be presented to this committee, and it was decided as to whether or not it was truly a surgical emergency and worthy of utilization of the resources that were necessary for the case that would clearly be taken away from the care of the COVID population. Everything from PPE to nursing staff to IV fluids, surgical masks, you name it, everything was in fact rationed. Next slide. So this is a sort of an overview of how we did it at the intensive care level. And as you can see above, we had 6 ICUs, each approximately a 20-bed ICU. That under normal circumstances, we had 3 different surgical ICUs and then a burn unit, and then 2 medical ICUs, Unit A and Unit C, that were the medical ICU and the CCU. We're Unit D. We had the only negative pressure rooms in the environment for the post-TB population. Within a week, we had about half of a census within our unit, half in the MICU, half in the CCU, and the numbers that were coming through the emergency room were off the charts. And we knew if we were going to continue to provide urgent and emergent care for both cardiac surgery and neurosurgery patients, as well as general surgery patients and some occasional trauma, although certainly the trauma went way down. There was nobody driving, nobody traveling, and pretty much nobody outside walking around, as New York City and Manhattan in particular just was evacuated. So they moved us into another part of the building. You can see we went from our normal spike down to what was really a post-anesthesia care unit. It was an 18-bed PACU that we converted into a mixed cardiac and neurosurgical and general surgical ICU. This was a completely COVID negative environment. Staff were tested regularly. Every patient had to be tested before they could gain entry into this unit. And patients who were positive did not undergo an operation, plain and simple. There had been some reports from the University of Chicago and others that the mortality for sort of elective surgeries in the setting of being COVID positive had a mortality of 20 to 25%, even for normal general surgical cases like cholecystectomies and hernias and laparoscopies. And so you really had to get through this committee to get a case done. And then if you were COVID negative and got your case done, everybody went down here. Our intensivists who normally run our unit were not available. They were redeployed to cover all these other units. Plus we had about a 45 patient ICU that was in the 23 operating rooms. Columbia did the same. And our fellows pretty much covered this unit 24/7. Next slide. But we did do surgery during this 3-month period. We did 54 cases, kind of a sick population, as you might imagine, with the usual comorbidities of hypertension and congestive heart failure, COPD, and diabetes. Next slide. And we mostly did patients who had urgencies such as symptomatic severe aortic stenosis, ruptured mitral cords, wide open AI for endocarditis, patients with ongoing ischemia after STEMIs and non-STEMIs, 3 type A aortic dissections, and 7 aortic replacements for symptomatic or rapidly expanding aneurysms. Next slide. We had 1 mortality, and that was in the patient who had the bad. She was a youngish woman who had had previous congenital heart surgery. She had Fontan circulation, single ventricle. She showed up at one of our regional hospitals in congestive heart failure and cardiogenic shock and was placed on VA ECMO. We transferred her to the main campus. She was COVID negative 3 times, but ultimately we couldn't wean her from VA ECMO, and because of her young age, she had to have a BAT. So she had a HeartMate 3 placed, and unfortunately within 48 hours, for some reason, converted to COVID positivity, developed a rapid and massive inflammatory mediated response with multi-organ failure, and that was our only operative mortality for the entire period. Next slide. So in summary, I think with, during a pandemic, certainly the systems were stressed. I think everybody responded in an incredible way of giving and really stretching themselves beyond what their normal limitations were. The hospital did a great job of supporting us, getting us PPE, ventilators, bringing in travel nurses from all over the place. And not only that, but the physician community from the greater New York area, New York State, and around the country. We had physicians coming in from all over the place to help. And you can do surgery in this setting. It just has to be done for appropriate indications, and everybody has to understand the need to conserve resources. So thank you very much.
Thank you, Len. Wonderful presentation. And, the whole country was watching your teams and learning from you on the go. And I think we all benefited greatly from the lessons that you learned. If this thing cycles back, which it might, I trust you feel more confident that you can continue some of your operations as they would normally occur and handle COVID in a different way. Is that accurate?
Well, Kim, it's unclear as to how that's going to go down. So as you know, we're starting to see increasing numbers here in New York. I can't say that it's a quote resurge, and nobody anticipates it to be at the same levels that we had before. But we have now 26 cases in our regional hospital in Brooklyn. We only had 5 2 weeks ago. In Queens, we had no chronics. We now have 27. And here at Weill Cornell, we now have 13 patients, and all 13 have come in the past 2 weeks. Columbia has about 25. You know, if it starts increasing rapidly, we have obviously a line of communication to the governor's office and the Department of Health in Albany, and we've been told that they are chomping at the bit, that they will shut down urgent and elective surgeries pretty rapidly if they think things are going to escalate. So we are uncertain as to what's going to happen, but we think we will be able to better ramp up if it, God forbid, should reach a pandemic level as it did before. We have plan A, B, and C in place for how we're going to escalate units. We have plenty of resources. I think this morning we did a count. We have 5.3 million N95s. We have over 10 million surgical masks. We have over 1,800 doses of remdesivir, et cetera, et cetera. So, I mean, the hospital's done a great job of trying to stay ahead, but it really is in the control of Governor Cuomo.
Well, we've really learned from your experiences, and we certainly thank you for all you've done, not only for New Yorkers, but for the nation. Let's move on then, and the next speaker doesn't need an introduction, Joe Caselli from Baylor College of Medicine. We're delighted to have Joe on the panel tonight. Welcome, Joe.
Thank you. Welcome, everyone. My job is to talk about this COVID-19 pandemic with a view from Houston. Are you controlling my slides there, or do I control here?
We control them.
I have them?
We have them.
Okay, go ahead and advance. I have no disclosures directly related to this presentation, with the exception that I did test positive at the end of June, and I was never sick for 1 minute. Next slide. So this is, we've had, worldwide, we've had over 36 million cases confirmed and over 1 million deaths. And in the US, we're well over 211,000 deaths. As you can see, we're here in the Southeast have a problem just like they have in New York. Only fortunately, our issues were far delayed from New York. And as Kim mentioned, we learned a lot from what happened in New York, how to manage these situations. And I think their educating us was to our benefit. The hotspots in Texas are in the Dallas-Fort Worth area, San Antonio, but the hottest spot in the state was really in the Houston and Harris County area. We've had over 16,000 deaths in Texas, so it's not been a trivial adventure. Next. So we've had 2 waves so far, one in the spring, one in the summer, spring being from March to early May. Things died down a little bit, and then in June and September, things popped up a bit. That did give us a chance to prepare for the second wave when we had a lull in the action, so to speak. Let's go to the next slide. So here's a bit what it looked like in this is for our hospital now, our individual hospital, which is called Baylor St. Luke's Hospital. It's in the Texas Medical Center. We have 145 ICU beds out of 854 bed capacity. So you can see this taxed us a great deal, because we were treating suspected cases almost the same as confirmed until they were ruled out. So even these suspected cases were part of this surge that came in late March and really carried itself through pretty much all of April. We're the main teaching hospital for the Catholic Health Initiative, which is a nationwide hospital network. And we have 5 hospitals here in Harris County area, and then multiple other hospitals, about 11 hospitals throughout East Texas. Next. So we did I'm sorry some of this slide overlies here, but we carried out, we had during this period of time where they had this surge, we dropped off of all of our elective surgery, much as Lynn described, and we moved only to emergent and urgent cases, with all the elective low acuity cases being held off for a period of time. This provided a 40% drop in our cardiac surgical work and allowed us to open up multiple ICU beds into pure COVID units, which were sealed off and managed in areas of the hospital that were in effect almost separated from the rest of the activity, with everybody going in and out, tested on a regular basis. And because we were delayed from what happened in New York, it did give us an opportunity to stockpile a lot of our maybe equipment, face masks, coverage, et cetera, all the things that Lynn described. So it did give us a chance to stockpile some of that. But even then, we were pushed to the limits and were on a rationing basis. Next slide. So this is what the Department of Surgery looked like from outpatient visits. You can see here we were pretty much totally face-to-face visits till this hit us in mid-March through April, and our number of visits went down precipitously. We lost almost but not quite half. And the point of this is we all rapidly learned to do these telemedicine Zoom visits with our patients, and this increased rapidly. This is just the Department of Surgery, but this was magnified and probably exponentially throughout the medicine departments and other divisions throughout the entire medical school. Next slide. So we had the spring surge, as you can see there on the left, which actually, after a relative flattening time, then we had our rear boom, a real important boom in the pandemic, which hit us. And you can see the magnitude of the summer surge here and what it did. This is not our hospital, but this is Harris County. We did a good job, I think, of managing the multiple hospitals throughout the Texas Medical Center. We all worked together. The administrations of all of the hospitals got on the same page, and it was a cooperative effort that was completely different than the usual competitive environment that we normally live in. Next slide. So we had quite a few, we had 5 ICUs. I'm not going to go through all those numbers, but the mortality of our patients going on ventilation was up to 30% during this surge. We maxed out at 103 patients in our hospital at one point in time. ECMO was not quite as busy, although the spring surge was significant. We have a maximum capability of in normal circumstances, of 12 patients on ECMO in our particular facility, and we approached that in the spring surge, and in the summer surge, we actually exceeded that. Next slide. This is a little bit of a busy slide, but I think if you look at the upper 2 drawings, you'll see here how the summer surge finally dropped off. And if you look at the green square there and look at the lower left-hand side with the October 2020 projections, one of the problems that we had, and so far we're following the dark green line, but the projections for what Lynn raised with the possibility of a fall increase in this virus and what it might do to our programs. You can see the multiple predictions of those various lines you can see there, and it's really all over the map. It reminds me of a great deal of the projections throughout this entire pandemic have been really very, very hard to predict what was going to happen next. The good news is that our positivity rate, if you look down at the red square, 9/11/20, we were down to 6.1, which is a very, very welcome thing. And the RT effective reproduction number, which has to do with how easily this virus is transmitted, was very, very high for a while. But fortunately, since August, we've been down to less than 1. And so we think that this is going to provide us this other window of opportunity of not having another surge, but we'll have to see. Next slide. So the question is we're going to have a winter surge, and are we going to be prepared? Well, we're in the process of preparing for that, rebuilding our supplies of equipment. And we've learned from the 2 previous surges, and on an organizational basis, the hospital capacity is now much more able and capable of dealing with high numbers. I will say that the TMC, the Texas Medical Center-wide disaster management, has been very, very effective. Just for an example, if one hospital began to exceed their numbers and capabilities, those patients would be shifted to another hospital where we had capacity. We've got 5 hospitals in the Harris County area just for our particular institution, and we were set up to manage moving patients throughout those 5 hospitals in order to have no one hospital which would be overwhelmed. We also set up a disaster management system with the CHI hospitals within Texas, which is about 14 hospitals with the same sort of process and availability. Our effective reproduction rate is now below 1. Fortunately, our new cases are really quite low, and our positivity rate over the last month or so has been less than 5%. Next slide. Next slide.
I think that's it.
I'm done then. Happy to take some questions.
So Joe, thank you very much. Very clear. And you brought up the point of the cooperation that we've seen, and I think Len would echo that. There's nothing like something of this nature to help us understand the value of working more closely together. And we watched this in Seattle, we watched it in Boston, we watched it in New York, we've certainly seen it in Houston. And, you know, these are some of the silver linings, I suppose, of a tragedy like we're going through. And we really appreciate your sharing the story from Houston. I think what we'll do now is go on and we'll get the story from Boston, but a little bit of a different twist. And we're going to ask Mark Lindsay if he'll give us a sense of how research was affected at the MGH. Mark?
Hi, can you hear me? Can you guys hear me?
We can hear you.
Okay. Well, I'm not showing up. Sec.
There you go.
It's coming.
Now we got you.
We see you.
Coming. There we go. Hi, everyone. Yeah, so I'm going to talk more specifically. It's nice to hear those stories of clinical resilience, and you know, I think it was great to see our hospital as well sort of rise to that challenge. But I'm going to talk more about on the research side, and I'm afraid, you know, I don't think the news is quite as good on the research side, but I want to define some of those issues and talk about them. How do I advance this? All right.
Mark, you can just say next slide and bring.
All right, next slide.
Yeah, Mark has control, so you just need to do it through the mouse.
Doing it. It's not.
There it goes.
Sorry, maybe there's a delay. So I don't need to go through, but obviously across the country and in Boston, we had, you know, shut down of non-essential activities such as medical research around mid-March as the cases and hospitalizations increased. And here at MGH, you know, during I think January and February, as we saw the cases accumulate in China and in Europe, you know, people were mostly talking about our supply lines and how that was going to affect research. You know, we were getting emails even as late as early March, you know, just saying, well, we think there may be some impact on research supply lines, but by mid-March, and it moved very rapidly, the decision was made to shut down basically all research activities at our hospital. And that involved basically sacrificing animals down to, you know, research animals down to just breeding lines, putting away all cell culture, shutting down all incubators, et cetera, and really evacuating the buildings as well. That lasted, you know, for about 2 months until, you know, we were allowed to start our phase 1 reopening, where we were basically just the PIs were allowed to come in and start making plans to reopen. And then during phase 2, which is basically what we're still in now, is about 50% capacity. You know, we have to have shifts for personnel, not to be in the building at the same time, to be 6 feet apart, inches, and we're allowed to now start rebreeding animals, and for those of us who work in animal models. You know, the information about how widespread this kind of thing is hard to get. There was one nice survey done by the Embl laboratory in Germany that looked and got about 1,000 researchers to talk about their experience across North America, Europe, and you know, about 77% had a full shutdown of research activity. About 20% had partial shutdowns. It's quite incredible considering the geographic distribution. And then the impacts were quite wide. 60% or so of life scientists report losing some of their work. You know, at least 25%, you know, up to 6 months of work. And obviously the wet labs, which are the labs that work with biologic samples, were much more impacted because you need to go in to lab, whereas a dry lab or someone who works on, you know, coding or you know, computational biology, you can still work from home, but both classes of researchers have reported decreased productivity. And then, you know, on the aspect of non-basic science, but on clinical research, I think there's been a huge impact. You know, as the trials and treatments for COVID-19 have really gained precedence, a lot of non-COVID clinical trials and clinical research have been de-emphasized, I would say. But also just some of the practical things, and this from my colleagues, in terms of having to retrain research staff to do COVID assessments, staff reassignments. You know, we had a fellow in my lab who got pulled to work in a COVID ICU, and that, you know, that's important, but is really, you know, impacted her research. And, you know, research related appointments missed, you can't fly on planes for a while, and delays in things like clinical imaging. You know, over the long term, I think these things are gonna lead to reductions in recruitment of ongoing trials, and you know, probably some clinical trials will be delayed because of this. We'll probably expect an increase in protocol deviations because of these impacts, and some delayed outcome, both of outcomes and adverse events. You know, and obviously COVID-related deaths can potentially affect your survival endpoints and power in these studies. I think this quote was pretty meaningful. In the medium to long term, we think that the delays resulting from the pandemic will negatively affect drug development timelines, which will unfortunately hurt the financial implications and lead to delays in getting drugs to patients. So what has the response been? You know, in terms of funders, you know, funders like the NIH and NSF and others have acted, and the Marfan Foundation as well, you know, to try to decrease the burden on medical researchers by decreasing the deadlines for progress reports, or even accepting late grant applications. The NIH is now trying to gather more information on the impacts of COVID-19. So everyone, if you get this email about you know, participating in these surveys, it is really important to tell the NIH how you're being affected. There has been a government response, although there's been no action on it. There was an act called the RISE Act introduced by Congresswoman DeJette in June to basically fund both coronavirus research, but also, I think importantly, research disrupted by the pandemic. And that's something that really needs to be done to support what is definitely going to be slower timelines, which just cost money. And then just one last note on, I think this is, and I think many people are thinking about how this is going to affect the training pathways for scientists and physicians, especially for people who are historically disadvantaged. You know, what we know about the pandemic so far in employment is that it's most heavily affecting women, primarily because of childcare. We're seeing a lot of job losses this September due to you know, kids not being able to go back to school. There's been sporadic, and I think, universities and hospitals are trying to react to these by things like tenure clock extensions or extensions of the ESI program at the NIH. What's really hard is the childcare solutions, which just aren't easily solved because of the pandemic. So just wrapping it up, I think this pandemic will have long-term negative implications for medical research for several years to come. We really need strong governmental action to preserve our biomedical research infrastructure, and I think we all see that that's not going to happen in the near term. And I think it's important to realize that women and minorities are being disproportionately affected, and we really need those people in power need to develop programs to support these folks and keep them being promoted in our systems. That's all. Happy to take questions.
Mark, thank you very much. I do want to encourage people who are on the summit tonight, if you do have questions you'd like to submit, you can use the Q&A function for that. Mark, you mentioned that you're still in phase 2, and I think all of us would be interested in what are the milestones that your institution is using to decide when you can move to phase 3?
I think it's mostly community spread, and I think their phase 2, although it sounds like it's an early stage, it's basically where we have to schedule shifts for people, so we have non-overlapping shifts and we have space, 6 feet of spacing and masked and so forth. I think that's going to be stable. I think they basically just realize we're not going to go beyond that to more opening until we're I'm not sure actually what the level would be, but we're not at it. And I think I honestly don't see it going away for some time.
Yes, thank you very much. Wonderful presentation, and certainly sobering, and I think we're all feeling it. The pandemic really came to our shores first in Seattle, and we're delighted to have Shireen Shalab presenting to us about lessons learned there. Shireen?
Thank you, Kim. Sorry, I have to adjust. Can you hear me okay?
Perfect.
Great. Well, thank you again for the opportunity to share that experience. And like you pointed out, we started in Seattle. So I'll take you a little bit of a different angle on this. All the talks have been fantastic about how this affected the clinical experience and the basic science research. I don't think I have control of the slides.
We'll advance if you just say next slide.
Request it from Bruno on the top.
Or you can try advancing on your end.
Okay, we can just advance.
There's a bunch of animation on the first slide.
Yeah.
So anyway, so going back to, travel or memory lane, if you will. So this was one of the early experiences as we became aware that the pandemic was hitting Seattle. And at the time, Ben Starnes and Nitin Singh, who are division leaders, were in communication with the folks in Italy, Italy was surging at that time, and we were not as much. But it was a very sobering email that he had sent to the group explaining what they were going through in Italy. And as a consequence, we ramped up on our end to say that we wanted to preserve our PPE and to be mindful of our resources. Around that same time, Tom Forbes from University of Toronto proposed this VASCON, similar to DEF CON in terms of thinking of the levels of what cases should be taking place from a vascular surgery perspective. And you can see that VASCON 5 was normal practice, but we were moving into VASCON 4, which is limiting the cases that we were taking care of at that time. And April was definitely a slow month for us from the perspective of canceling all the elective cases and rescheduling patients. And you can see this is where we were in terms of the case numbers at that time. It just seems like such a long time ago. So some of the unintended consequences that happened, next click please, is that, and the next one, please, is that there was this growing sense of community among the vascular surgeons using these virtual spaces and social media basically to communicate and share stories and lessons learned from each other. And what was phenomenal about that is and I'll get to what's phenomenal about that in the next slide, but this is as in our early cases and sort of learning how to operate on people in these space suits, which are quite uncomfortable actually, and it's there's definitely a little bit of a learning curve to that. So next slide. So the unintended consequences, because there's a lot of this discussion among vascular surgeons, we wanted to capture that experience from a vascular surgery perspective, to see how people were dealing with the impact of the pandemic on them. And so we sent out this anonymous cross-sectional survey. It was sponsored by the Wellness Committee from the Society for Vascular Surgery. And basically, we also had the general anxiety disorder 7-item scale and brief cope, which is a coping assessment survey, as well as asking specifically about the COVID-19 related stressors in people's community and a qualitative portion. And you can see again where the red arrow here on the right, that's where the number of cases were at the time in the United States. Next, please. And so we received over 1,600 respondents from 58 countries where people shared generously their experiences. And you can see, as what you'd expect with vascular surgery, we had a little bit more women than what we normally have for women. So in vascular surgery, there's 12% women, but for this survey, we had 29% women respondents. Next slide. And this is just the experience in the United States. The map up top shows you by percent or by concentration of where we got the responses. So the darker the state, the more responses we got from that particular state. And then we looked at the regions, Northeast, Southeast, Midwest, and West, Southwest. So you can see that the Northeast, of course, as you would expect, was the most heavily hit at that time, where there was less number of available ICU beds. But across the board, most elective surgeries were canceled. Almost close to 90% of the cases were canceled. And also across the board, there was reduced clinic availability. There was wide adoption of telehealth, which was, I can say personally, in our institution, there was rapid dissemination and implementation of telehealth and making that available. So that was quite remarkable. And then you can see that in terms of redeployment, that there are vascular surgeons who were redeployed into the ICUs or other services other than being a vascular surgeon, and most of that was in the Northeast. Next slide. So what we learned from that survey, especially looking at the anxiety scores, in general, I would say the vascular surgery group is a chill group, so the scores were relatively low, so that's not a high anxiety group. However, on the higher end of the anxiety, you can see that it was related to concerns about negative consequences of care delay to the patients. That was a very strong running theme. And you can see this word cloud. And when we saw this, we chuckled because this was the constellation, if you will, of the qualitative component where people just wrote about their experiences. And the word patients was the most commonly used word in their responses. Of course, they were worried about their family and friends and colleagues being infected with COVID-19. And the changes in home routines were stressful. So people who couldn't get home or who were having to stay in a hospital or even had a separate room in their house, that created additional stress for them. And of course, there was financial concerns, particularly in people in private practice. And what was also a valuable lesson is that people who felt supported by their hospitals, and we had asked a bunch of questions about hospital support, such as adequate PPE, having COVID testing available, having transparency from leadership and just knowing what's going on, that actually people who scored high on that scored low in anxiety levels. So this was a tangible thing that we could offer to say that having hospital support was something that is useful for surgeons and, by extrapolation to other physicians. Next slide. Other things, sort of these are, again, the unintended or positive consequences. For example, this is one of our studies where we're enrolling patients. It's a community-based enrollment that was already in place. And based on patients' feedback, we had created this virtual enrollment using DocuSign and not mailing in any documents and transition from doing paper type enrollment to actual just virtual enrollment. And so this is one study that actually was able to continue without losing a beat, just because, again, people were able to do this from home, for example, and there's no travel required. So there are definitely some valuable lessons learned from there, and what are the things we can do to continue supporting research and making it move forward, at least in the dry lab type environment. Next slide. And just like Dr. Lindsay mentioned, there's funding, additional funding from the NIH, which we're interested in understanding the impact of COVID, but same thing from PCORI, Patient-Centered Outcomes Research Institute. We had just started the Aortic Dissection Collaborative in late 2019 and had a community survey in place where we were surveying people. And clearly when the pandemic hit, those numbers, of people responding have dropped. But meanwhile, we were able to apply for that supplemental funding to assess the impact of COVID-19 on people with aortic dissections and implemented this COVID-19 survey specifically. And that survey just closed. Next slide. And this was just last night. I looked at, again, the closed survey, and just to kind of get a sense, you can see we had 344 respondents with aortic dissections and 304 people who are at risk for aortic dissections. And we specifically asked them about clinic cancellations and surgery cancellations since the month of March. And you can see that 40% and 53% respectively in each of these groups had clinic appointments canceled, either because they canceled the appointments or the hospitals or the clinics canceled the appointments. And we'll delve in more deeply. There were not many surgery or people who underwent an operation during that time frame. You can see the numbers are relatively low, but you can see that about half the people who had an operation scheduled during that time also had their surgery pushed back and delayed. And so, again, we're diving in a little bit more into that, and then we'll have some qualitative interviews with the patients to better understand the impact of COVID-19 on their aortic dissection care. So that's all I had for slides, and thank you. Happy to answer any questions.
Thank you very much, Shireen. The survey particularly is very, very interesting. And as you think about the impact on clinical research at your place, have you been able to leverage the ability to, say, do informed consent digitally and not in person? Do you feel like you're ramping that up now, partly as a consequence of the pandemic?
So I'm hoping, this is one of the things I'm presenting to our group about this virtual enrollment. I think it's not that tedious once you figure out how to get it through the IRB. And I think that's a great way to transition, particularly if we don't think this is going to let up anytime soon. And so I think that's one lesson that we can take away from this experience. And maybe that's in the long run, it may be cheaper than having to do the pen and paper and the in-person type visits.
Yeah, I think it's entirely possible that the lessons learned both in virtual care and virtual clinical research could end up being far stronger going forward as a result of having to go through this. Like Joe said, I think others said, the ability to provide virtual clinical care at all of our centers, it had to go up. We had to figure out how to do that. And as a consequence, I think our care will probably never be the same. I also think that clinical research consent has the chance to really evolve quickly in a way that's more friendly to our patients and doesn't require drives and parking and all the things that typically they deal with. Any other comments before we move on, Shireen?
None from my end. I think, this is, while it's an unfortunate event, this is the time to make lemonade out of lemons.
Yes, I think, we want to pivot from victim to victor. And certainly we've learned some things for you tonight that are really important. Thank you very much.
Thank you.
So now we're going to go north of the border and Morale and Uzunian. Is that right?
That's correct. Yeah.
Oh God, I'm so sorry. I'm really tough with names.
It's no problem.
Thank you for joining us.
Thanks very much for having me. We're going to shift gears a little bit to perspective from Toronto. I've really enjoyed hearing the talks so far with the fantastic experiences in the US. Next slide, please. So this is a quick snapshot of COVID in Ontario. We had our first wave slightly after New York, and we saw at our peak of our first wave about 600 cases a day. The percent positive rate was 12%. Total in Ontario, 250 people in ICU at its peak, and 50 deaths per day. In the entire pandemic, we've had 50,000 cases in Ontario and 3,000 deaths. So certainly, slightly less than many of the areas affected in the US. Click, please. We are seeing second wave now. We're back up to 600 cases per day. The difference here is that we're testing far more patients. So now we're testing 50,000 patients per day. Our percent positive is still quite low at 2%. And our ICU total in the province remains at 50 with deaths at 5 per day. You can click again. So you can see that although the case numbers in the province are at the same now as they were in our first wave, there are younger patients who are being affected right now, fewer patients in the hospital, fewer patients in our ICU. Next slide, please. So what was the COVID response at Toronto General? So we had a swift and really severe reduction in all elective surgery on the 16th of March in anticipation of the surge. We were essentially watching what was happening in New York and were very, very concerned. And we had early implementation, very early actually, of universal masking of all staff in the hospital, universal screening of everybody walking into the hospital, visitors no longer being allowed. COVID testing was implemented for all surgical patients, and we had in-house lab testing with quite rapid turnarounds. We had COVID wards and ICUs, but really nothing like the experience in New York or Houston. We are, however, the regional ECMO center for the area, so we did see quite a bit of VV ECMO here. We had at our peak 10 patients on ECMO per day. We had a total of 35 patients on ECMO in the first wave, and we're slowly starting to see a couple of patients again on ECMO. But cardiac care was really drastically reduced during the pandemic, during the first wave. Next slide, please. So specifically for aortic care, all elective cases were deferred, and we gave specific consideration to the fact that, especially for complex aortic surgery, such as thoracoabdominal repair and redo arches and so on, these patients do not have, 18-hour stay in our ICU. They take ICU resources and also take significant resources from our blood bank. So those were sort of immediately shut down. Next slide, next click. We reserved surgery for patients with acute dissection, also patients with very large aneurysms, and we left this a little bit to the discretion of the surgeons. If they were growing quickly or you were worried about the patient, you could still bring them in for surgery, but the numbers, we were down by 80 to 90% down in our volumes through the early months of the pandemic, so care was really reduced. Patients who had severe valvular lesions and concomitant coronary disease, we were still allowed to go forth. Next slide, please. We had a drastic reduction in what we saw of patients presenting with acute type A dissection. We only did 3 cases total during the first wave, and we did have patients present. We not only anecdotally, but across the region, we saw patients coming late presentations with days of chest pain, dying before they were transferred, and so on. Next slide, please. So in terms of cardiac care, we had a really dramatic increase in our wait times with the consequent increased risk of death on our waiting lists and risk of clinical deterioration on our waiting lists. We saw, as many other jurisdictions have seen, more presentations for urgent and emergent interventions, patients presenting with ischemic VSDs and papillary muscle ruptures who we really hadn't seen we had seen very few of before the pandemic in recent times. But we had, even now we are seeing patients whose ejection fractions have declined because their severe aortic stenosis operation was delayed for so long, and so on. So the shutdown was, I would say, quite severe and also quite long, even though our COVID cases in Ontario throughout July and August were really low, less than 100 cases per day in August in all of Ontario. We really didn't ramp up our operations until September, close to normal. Next slide, please. In terms of COVID care, we did reasonably well. I would say not the best, not the worst. Our mortality for COVID in all of Canada is 1.2% if you exclude people in nursing homes, and 81% of deaths in Canada have been in long-term care facilities. And in fact, at the end of the day, our hospital infrastructure was not overwhelmed during the first wave of the pandemic. Next slide, please. So lessons learned, I would say we really need flexibility, and we need to be agile to ramp down and also ramp up swiftly. We saw that we could really ramp down very quickly. You shut down elective surgery. We cleared our ICUs out really quite quickly to make room for COVID, but our ramping up has been, slower than ideal, I would say. Next click. We need to keep a reduction in community spread, and this is very important to maintain healthcare delivery. What we're seeing now with the second wave is not so much that the COVID numbers in the hospital are rising, but that nursing staff shortages, OR and ICU resources are being affected. Kids are being kept home from school because someone in the class is sick, and healthcare, childcare and so on is a major concern. The waiting time for tests, the backlog for testing has increased. And so we're seeing now really a reduction in our ability to deliver cardiac care, not because we're overwhelmed by COVID, but because community spread is increasing again. Next click. We certainly need comprehensive and accurate data regarding the impact of COVID on cardiovascular outcomes. Anecdotes are fine, but they really are insufficient to argue for our administration to actually provide cardiac care during these times. So we have partnered with the province. We're looking at volumes of PCI, coronary surgery, aortic valve surgery, TAVR, etc., and seeing how people are doing on the waiting list, risk of death on the waiting list, and so on from a province perspective. And we're hoping that those data will help us advocate for our patients more strongly. Next slide, please. And certainly we saw, as did everybody, that the need for frequent and transparent communication is crucial, really, to reassure our cardiac teams that coming to the hospital and patients that coming to the hospital is safe. Next slide, please. So I would say in Toronto, we saw a swift, severe, and really prolonged reduction in cardiac care in response to COVID. And in my opinion, patients with aortic and cardiac disease were put at risk. We must advocate strongly for our patients through the second and third waves as best as possible. Thanks very much for your attention.
Thank you, Morel. Very, very nice presentation. It's just striking that the fear that the pandemic has created for individuals coming to an emergency department has been so high that we've seen all over the world this tendency for patients to stay away, even with really bad problems, MI, dissection, etc. And has your institution or the province or Canada in general done kind of an advertising campaign to try to help patients understand the likelihood of getting COVID when you go to an ED is a lot less than the likelihood of getting hurt by a cardiac problem?
Mm-hmm. I would say there hasn't been a sort of formal, systematic, comprehensive campaign, but there are certainly on social media, hospital groups and patient advocacy groups. We have the Genetic Aortic Disorders Association of Canada, GADA, and the Lois Dietz Society of Canada, and so on, speaking to our patients, telling them to not defer seeking care if they have an urgent problem or severe acute onset chest pain and so on. But there hasn't been a formal campaign, but certainly a lot of individual offices. We've kept track of all of our patients on the waiting list, and we throughout the early days we would call them every 2 weeks, see how they were doing, update their clinical status, and sort of triage how they were doing clinically. But we really some people still weren't willing to come, even though they were developing clearly signs of severe heart failure and so on. And the fear, despite us reassuring them that the COVID ICU is separate from the cardiac ICU, the OR is actually one of the safest places in the hospital because everyone's tested and everyone's, all in PPE and so on. And certainly the cardiac ICU and wards wards were relatively safe. We did not have nosocomial transmission to a patient on our cardiac ward during the first wave, but it's still certainly people who are asymptomatic would not come for sure. And even those with severe advanced symptoms are still even now reluctant to come as we see the numbers increase again.
Yeah, there's no doubt that we need to do a better job in community education to try to get over this hump with that fear. One of the things I'm excited about the GenTAC Alliance is that there was a big effort to go global and to have this be much more than a US collaborative, and we're certainly grateful to partner with you, Morale in Canada. And our next speaker is from the United Kingdom, Toru Suzuki. So Toru, we're delighted to hear from you today.
Mute. Hi, good evening. Can you hear me now? Great.
Hear you.
Great, Kim. Thanks for this invitation. I'd like to talk to you about, what we're doing. Oh, start my video. Okay, sure. So I'll talk about the UK. Sorry, there's something prompting on me. Start my video. Should I click this? But anyways, so I work at the University of Leicester, but our University Hospital, Glenfield's the main cardiac specialist hospital in the region. It's also the main ECMO center nationally. So since March, we took a bulk of the severe COVID patients and remained a COVID hospital until summertime almost. I do also run the aortic medicine program at our hospital as well, which switched over to telemedicine soon from March onwards. But the most impact we've seen is the great drop in the referrals that we get, because in the British medical system, patients need to be referred from primary care from the general practitioners, but because the general practitioners are also doing a skeleton service without face-to-face visits, they're not referring on to the hospital specialists right now. And so we've been seeing that. Urgent care is going on as usual. We had 2 arch dissections last week alone. Our multidisciplinary team meetings, which are face-to-face, where we get everybody in the room, just started kicking back from September, a month ago. But right now, we're already in the second wave here in England. Yesterday, we had 18,000 new positive cases of COVID, but it was only 6,000 last week, 1 week alone. So we've had a 3-fold increase in the last week alone. The maximum we had in springtime was 5,000 cases a day. So we've exceeded that already. The city just north of us, called Nottingham, has a positive infection rate right now of 700 per 100,000 population in the last week alone. I don't know if you guys are following numbers, but 700, the last time we had our lockdown, the maximum was 140 per 100,000. So 700 is sky high for us. It's 5 times higher. How this will translate into hospitalizations and severe patients is something we are very cautiously watching right now, because we're not sure how it's going to be, because this is 3 times higher in just the last week alone. In our hospital, we have about 50 patients hospitalized with COVID right now, but we also have what are called Nightingale field hospitals throughout the country, which are all on 48-hour standby right now. So we're not sure how this second wave will translate into hospitalizations and severe patients, but we are watching cautiously. Now for acute cases, I was just going to go into some data that we've got from England right now. Although the slide shows acute coronary syndromes, what I wanted to show is that there's been a severe drop in patients coming to hospital. So this is about admission rates. It says acute coronary syndromes, so please just think of it as admissions for heart disease. But during the pandemic, we had a 35% drop overall for ACS, acute coronary syndromes, or NSTEMIs as well. Not as much for STEMIs. Please disregard the difference between the red and blue. It's just the basic curve should be fine to understand this. Um, okay, can I ask for the next slide, please? And when you look at, this is data from Paris, the out-of-hospital cardiac arrests during the peak of COVID went up 100% at the time. It was ridiculously high. So we know from the European experiences where it's a public health system that people are dying outside the hospital. That's the bottom line. Next slide, please. So the ESC did it's called a COVID survey. I know these are really small, but the question was, have you perceived a change in the number of people coming to your hospital with ST elevated myocardial infarction since the coronavirus outbreak? And the answer was yes, in about 80% of medical practitioners that responded to this. But the second question was, by which percentage? And as you can see here, it's the bulk of the responses were upwards of 40% and higher. So that means that we're seeing very severe, drastic reductions in the number of patients coming to hospital right now. Next slide, please. So in the last week, we just got data on cardiac deaths during the pandemic. This is British data. This is a very busy slide, but the blue is total. These purple lines are non-COVID and the red ones are COVID. So if you look at cardiovascular death in hospital, the COVID ones are a bit high, and those for non-COVID and in total are lower than usual. But when you look at these for cardiovascular deaths at home and those in care homes, the COVID deaths are almost a baseline, but those in total, basically these are pulled by the non-COVID deaths. You can see these are going incredibly much higher than those that you see in hospital. Basically what it's telling us is that patients are dying from heart disease at home and in care homes. Next slide, please. So there is some granular data, stroke, ACS, heart failure, and there's one for aortic disease as well. But the statistics for hospital statistics tells us that we're not seeing a rise in aortic disease death yet. Although our impression is that we're seeing about 50 to 60% reduction in hospital presentation for aortic disease. The deaths are not seen. However, when you look at others, such as stroke, acute coronary syndrome, and heart failure, there is a difference. Next slide, please. And when you look at the data here, for example, the red one is hospital, the blue one's home, purple's care homes. Strokes are increasing in care homes, ACS at home, but for aortic disease, so far so good. We're not seeing any difference, but again, this is based on hospital statistics, so we're not sure, but this was data that was released the last week. Next slide, please. So the NHS, the National Health System of the UK, I mean, this is what went out to our medical practitioners. It was say, don't delay treatment, the NHS is ready for you. But this was also accompanied by public announcements telling people in the, through the BBC saying, if you have a heart problem, if you think it's urgent, or even if you don't think it's urgent, you need medical care, come to the hospital. We're open for urgent care was the message that's gone out. Hopefully we'll see an increase in cardiac admissions and cardiac treatment, and hopefully we'll see less deaths outside the hospital moving forward, but it is a challenge right now that as we got the second wave as well. Thanks for your time. Thanks.
Taru, thank you for sharing it. Obviously, having the ability to look at nationwide statistics is just incredibly useful for understanding what's going on in the community. And you mentioned Nottingham. As you compare your community to that one, are there any messages that we should learn about the reasons for the rate skying there?
Sure. Nottingham uses a lot of public transport. Old style surface trams in the center of town. Not enough people use masks when they take public transport, I think is the bottom line. I mean, that's not the only reason, but that's one of the reasons. Leicester doesn't have surface trams. We have buses, but not trams, so yes.
Okay, I got it. It's hard to get your arms around the aortic dissection rates, we think that about half of dissections die at home when we're not having a pandemic. And then, what percentage of the rest are staying at home and passing there? It's hard to get your arms around. A lot of centers have told me, just like Len said, that they were seeing a downtick, but actually at our place we saw an uptick. I'm really not sure what was going on with that, but it certainly is concerning that somebody with a catastrophe like that would sit at home and pass because of it. And you're right, we've seen a lot more complications of non-reperfused ST elevation MI than since I was a fellow, VSDs, mitral valve dysfunction, etc. Does anybody want to pose a question to any of our speakers? I think that we've really benefited from all 6 of your presentations. They each attacked a slightly different angle for this. Obviously, we're all still learning about this pandemic, and hopefully we can learn from each other. I think tonight we certainly did. I want to thank Len Girardi, Joe Caselli, Mark Lindsay, Shireen Shalab, Meryl Ozunian, and Teru Suzuki for their presentations. We're going to take a break and let you go get a drink or a bite to eat. And at 7:30 prompt, we are going to start our live poster presentation, and we'll see you back here in just a few minutes. Thank you.